I am coming from South Florida. I am a pain specialist in private practice in a large multi-site South Florida practice. I'm also an addiction medicine specialist, and I've got 10 minutes to talk on the collapse of opioid care in the United States. So it's a pretty weighty subject. Henry Young is on the faculty at the University of Florida. He's an emergency medicine physician. He just recently finished a NIDA T32 at the Department of Epidemiology at the University of Florida. And I have no disclosures. This is a well-worn slide. Wish I had a penny for every time this was used. So we'll just look at the purple line representing prescription opioid mortality. And we can see, a fairly concerning rise that starts creeping up and gets to be really very noticeable around 2008, 2009. We started getting some publications about concerns on prescription opioids. And, in the state of Florida, I overlaid some policy interventions in that state, but they're probably representative for policy interventions in the United States. And they're 2010, 11, 16, and 18. So 2010, Florida just started with their policy intervention. Really wasn't revved up. 2011, they came out with Florida Statute 45644. Which was pretty heavy-handed and really started to deform or to put pressure on opioid prescribers. It required, if you were prescribing, anything more than just a little opioid, you had to register with the state. You had to refer to addiction medicine or to psychiatry and so on and so forth. And then, of course, the infamous or famous CDC guideline. And then also Florida came back again with House Bill 21, which it imposed additional obligations. So if you look at the inflection on the prescription mortality line, it kind of flattens out once these policy interventions hit. We collected IQVIA data on dispensing, and we reported on that, and that's in that rectangle there, and I'll show you what we saw. So throughout our study period, there was a decline in opioid prescribing in the United States. This is US aggregate data, and it's dispensing data, but it's synonymous to me with prescribing, so I just say prescribing, if you allow that. So there was an overall decrease of about 30% throughout the study period. What's really very notable here is as we see a decrease in the share of opioid prescribing in primary care, we notice an increase in pain medicine. The other specialties are relatively minor. Down at the bottom, things like neurology, different surgeries, OBGYN, pediatrics, and such. So this is a tabular summary of our data. You can see a decrease in morphine milligram equivalent nationally throughout, with the least decrease in pain medicine. If you look at just prescriptions, which isn't that helpful, you'll see an increase in pain medicine, but overall a decrease in prescribing across the board in the study period. So the CDC was problematic in several ways. Now, it was said that CDC only applied to primary care, and it left pain medicine to deal with more complex, high-risk opioid prescribing. But right out of the gate on page 3, and these are verbatim excerpts taken from the document itself, that the focus is on primary care, but it also refers to pain medicine specialists. So we're not off the hook there. And, CDC preferentially drives problematic and high-risk opioid prescribing into the pain medicine space. If you have escalating dose requirements, if you have what they define as high-risk opioid prescribing, send to pain medicine. Some states require by law referral to pain medicine in certain high-risk situations. If a patient's taking a high-risk regimen, or if they're taking opioid benzodiazepine, or if they experience an overdose, or if they have warning signs of a serious adverse event, send to pain medicine. If you want to maximize pain treatment, send to pain medicine. Consider consulting pain specialists for people with history of substance use disorder. And you know, the wording consider, maybe, recommend, we suggest, you know, that translates to you really must do it. And it's just a quirk of both human behavior and also enforcement systems and whatever. I mean, that just means you're liable, you know. So we all know that that's secret code for send the patient to pain medicine, or, you know, your butt's going to be on the chopper. Excuse me, pardon. Can we edit that out? And again, another reference on page 32. So there's 7 instances within the document where they promote and they continue this fantasy, or it's not really a fantasy. Actually, it actually is probably well-founded that pain medicine is a great specialty for high-risk opioid prescribing, but there's a problem. So there's about 250 to 300,000 primary care providers, depending on how you slice the data. There's only about 5,000 pain providers. So pain medicine is a relatively understaffed workforce. We're overburdened. Small transfer of opioid, you know, relative percentage from the primary care space translates to a significant burden per provider in the pain space. And this is other data that is coming out of UF. If you look at burden per provider in specialties, you see these 4 specialties here. You'll see pain medicine far and away is overburdened, relatively speaking, when compared with other specialties. And we did look at 2015 versus 2017 in an attempt to detect an effect from the CDC, but we didn't see one because if you remember back there was already a trajectory. There was already negative movement of opioid prescribing. And if you remember when the CDC hit, it really didn't have any inflection on prescribing. And this is prescriptions per provider above 100. It's about the same as 50 to 100. Again, pain medicine overburdened per provider. So another problem is the transfer from the primary care space into pain medicine is not bidirectional. And there's a collapse, you know. I'll show you later on. Philip Coffin and Antje Barveld just published an NEJ, and you know they were describing the collapse of prescribing in primary care. Well, now that the opioid prescribing has been compressed into the pain space, and our data only goes through 2017, I would suggest that it's certainly more significant present day. In my community, pain medicine has stopped prescribing. My colleagues in the community have either stopped prescribing or drastically cut down on morphine equivalent. I cannot send my patients, for whatever reason, if they go out of network, I can't get another pain practice to take on their care. I had a patient with 105 morphine equivalent. I couldn't send her anywhere. The one place I was going to send her said, yeah, I'll take her, I'll put a pump in her at 105 morphine equivalent. So unfortunately, you know, really the ideal thing would be to include behavioral medicine and addiction medicine, but that's a very undeveloped pathway. The main pathway out of pain medicine, if a patient can't be treated or if they wind up taking too much medicine or some of the other reasons elucidated, is out of scheduled care. They exit the healthcare system. And, you know, the street, diseases of despair, they wind up on the doorstep of emergency medicine. So this was from 2019. So it was already, you know, raising alarm that primary care, in this particular study, half of the primary care providers in 2019 would not accept opioid patients. So when the primary care space collapsed and people moved into the pain space, now the pain space is collapsing. And this is a crisis. This is unfolding right now. So this is last month. So Philip Coffin and Barveld, you know, they were saying we're at the precipice And, you know, I think we're past the tipping point. So it's a very serious problem here. So access to opioid care has been threatened ever since we noticed a rise in opioid-related mortality, prescription mortality. The specialty of pain medicine is regarded as the ideal destination for opioid prescribing, and it's become the last resort. So we've got widespread complex systemic drivers, both within and without the healthcare system, that are continuing to exert pressure on pain medicine without compensatory cultural, technical, and policy supports. We're just not getting the support we need to maintain the complex high-risk opioid prescribing, or even to now tapering is a completely different issue. And even that's not well supported. Policy-wise, I mean, down at the grassroots level. So we're collapsing in pain medicine, and patients are vulnerable, the ones that are opioid disordered or ones that are living with complex persistent opioid dependence, and they don't transfer easy and there's no place to transfer them to. So please don't misapply the guidance. Be very careful. Look at your opioid treatment agreements. Make sure they're not dysfunctional or toxic or promoting this, crisis. Please be aware of problems in the system and the under-supported condition in pain medicine and the overburden. And we really need to update our study in those various points on the healthcare system graphic that or chart that I showed. We need to let the policymakers know that things really aren't working. We really need to support pain medicine. We need to really support the transfer to addiction medicine. We need to get behavioral medicine revved up. And we need to treat OUD in situ, that is in the practice where it's found, or we need to effectively transfer. We cannot continue to practice the way we do, and that is if you have a problem with opioids, like if you test positive for fentanyl, non-prescribed, or you're overusing, out the door you go with a little pat on the back. That is just not the way for things to work here. We have a survey. If you want to shoot that and do it, that's fine. If you don't, please feel free to contact me or Dr. Young, and that's it.